Mr. Scott.
My lady. Professor McBride, for the break we've been talking about communications. I'd like to carry on with that thread. If we can please have on the screen INQ 000 445 772. And if we could please start at ideally page 3. I will just summarise that. So there's an email that had been received by the Health Minister on the 17th of March, I think from a nurse, commenting on concerns about downgrading of PPE. Do you remember?
I do, yes, thank you.
And if we can please go to page 3. That email was then, if we can scroll up, please. Thank you. And then that is your email and response, because that email had been passed on to you from the Minister's private office.
That's correct, yes, that's my response, yeah.
Yes. You're talking about the nature and volume of correspondence from health professionals, nurse, doctors and others is entirely inappropriate, even allowing for the current significant understandable anxiety. You're talking about no circumstances of escalating such matters. That's what COSA practice for. It doesn't... Well, if we can just go up, we'll continue with the thread. You have the response from the Chief Nursing Officer, who agrees it's not the right approach, but she is reflecting the fact that there is significant concerns, and at the bottom paragraph there's a deep lack of clarity and understanding regarding appropriate use of PPE, and in particular FFP3. A professional letter on its own won't do it for me. We need to reissue simple and clear advice and information. And then your response is, the guidance is clear, whether clearly communicated, understood and applied as separate considerations. Do you think that there was sufficient communication to healthcare workers in Northern Ireland about what the standards were of PPE that they should be wearing in order to assuage the concerns that they had?
I mean, clearly at that time, given the volume and nature of the concerns that were raised, there was much more that needed to be done to provide clarity on the guidance and the rationale for the guidance, and actually to address what were genuine concerns and anxiety. I mean, there was a real sense of fear, which was entirely understandable. These were individuals who were putting themselves in harm's way in the treatment and care of others.
Did those communications come, given that they'd been raised with you?
Well, they had. I mean, the first communication on infection prevention and control, whilst I wasn't directly involved, had issued in the 10th of January. It was in line with an agreed approach across the UK. It issued from the Public Health Agency in Northern Ireland in conjunction with other organisations, Public Health England, etc. at that time. The difficulty
but this is the 18th of March. This is after the downgrade from HSID. So,
and what I was going on to say was that from that date there was a subsequent revisions and updates to the guidance. Now, I think what this is specifically concerning is the decision in and around mid-March to change the PPE guidance on the basis that COVID was no longer considered an HCID. So clearly in that transition from the advice around PPE that was being provided and infection prevention control that was being provided prior to that decision, there was clearly not a clear understanding of the rationale for why that decision had been made. To my mind, what I was flagging here was, and we've covered this in the CMO technical report, there were significant issues around the clarity of the communication, the ownership for the responsibility to ensure that was communicated by employers to their staff in a consistent way.
And did that clarity come in Northern Ireland?
I believe that clarity did come. There were a number of actions that were taken on foot of this. For instance, the Chief Nursing Officer developed a range of guidance videos around appropriate PPE. Now, again, it's beyond her remit as Chief Nursing Officer, but she worked very closely with the Director of Nursing within the PHA. The IPC cell was subsequently established with its first meeting on the 20th of March.
I appreciate all that, Professor McBride. It's simply a matter of, I asked, did the clarity come? You say believe the clarity did come. Were you receiving concerns subsequently in 2020 from healthcare workers that the level of PPE that they were being advised to wear was not sufficient?
I think that I gave you specific examples of action that was taken on foot of this. I mean,
Well, first, could you please answer the question about whether you received those concerns rather than the action that you took?
well, concerns continue to be flagged throughout the pandemic, not just in 2020, but certainly each time that there were new variants which emerged. Again, the evidence around transmissibility and infectiousness was reviewed by UKHSA, was reviewed by IPCCL. There were specific subgroups established to look at the evidence, but it was a continual challenge, understandably, to provide the latest evidence-based guidance and to ensure that that was understood by all concerned. I think there were reasonable questions. I think we need to anticipate that in future pandemics, but there was considerable effort made to ensure that there was an understanding. We did, subsequent to this, publish on the 28th, I think it was around the end of March, the further letter from myself and the Chief Nursing Officer, which advised on the guidance, published a link to the evidence base so that individuals could look at that evidence base, and it also contained leaflets and a link to a video about that PPE. So I think we took concerted action, but that did not prevent concerns being made after this date, and those continued throughout the pandemic about the appropriateness of the IBC guidance and about the appropriateness of PPE guidance.
I want to move on to the 20th of March direction to the RQIA. I'm not asking from this from a care perspective. The direction was given effectively for the RQIA to cease inspections of hospitals. Is that correct?
To pause the inspection of hospitals, yes.
Yes. Did you consider whether it may have been a better alternative for the RQIA to have had the ability to inspect hospitals as they ended up doing later on in that year, they were reviewing IPC measures and how those issues were being applied, things that were directly relevant to healthcare workers during the middle of the pandemic?
There was a need, in terms of did I consider it, yes, that was part of the consideration, but there was absolutely a need to ensure that we reduced, in as far as possible, all unnecessary footfall into healthcare facilities so that we could protect individuals in those facilities and staff in those facilities.
Okay, can I just ask, in terms of unnecessary then, how many people will come in from the RQIA if they were to conduct an assessment of the IPC measures?
If you're talking about a trust, it would be a team of individuals would come in from RQIA. And again, I would just point out, and again, that separate to the arrangements in England, RQA does not have a regular programme of planned inspections in hospitals in Northern Ireland. They are not registered with RQA the same way that CQC is. So the inspections that RQA undertake tend to be thematic inspections, which we request, as of you alluded to, the hospital inspection of IPC in September, which I commissioned from RQIA.
And that produced some useful recommendations and points of learning. So, on reflection, do you think that there would have been a benefit for the RQIA conducting IPC reviews in hospitals at an earlier stage in the pandemic, particularly when trusts are starting in the early stages of their response?
I don't. I think that there is significant IPC expertise already within the health service in Northern Ireland. As I mentioned earlier, there are infection prevention control teams within each trust in Northern Ireland. Each trust can draw on the support of the Public Health Agency, which again has expertise in infection prevention control if they have any concerns, or, for instance, if they have an outbreak. So at that stage, I did not believe, and again, I still do not believe at that stage that there would have been added benefit from a regulatory approach with RQI inspection.
President Bragg, can I also ask what happens from the hospital's point of view? If you send in an inspection team, presumably they don't just wander around the hospital on their own. Members of staff have to respond to their questions and show them around. So, I mean, how many members of staff are you taking away from their other duties to respond to the inspectorate?
Again, I would be speculating, Chair, my lady, but a significant number of staff, because what RQI do in their inspections, I mean, RQI are also different in they are professional inspectors that are all registered nurses, allied health professionals, or social workers. So they inspect clinical and non-clinical areas. They meet with staff, they meet with visitors, and they do go where they choose to go because that's the purpose of unannounced inspections. So it would have been, it certainly, and again, Ian Tranholm, I note in his evidence to inquiry makes that point, that it would, to continue inspections would have added further pressures to an already pressurised service, with staff being pulled in multiple directions. So in my view, and I think Breach Donaghy, who is the now chair of RQI, said in her own statement, and I would agree and concur, that the pause in hospital inspections had likely to have minimal impact in relation to the work that RQI carries out in the statutory sector.
Yes, thank you. I don't need to take you to Ms Donaghy's statement now. Can I please deal with prioritisation then? If we can please have on the screen INQ 000 474259, and it's page 217. It's paragraph 503. This is the spotlight statement from the Belfast Trust. And then, as you can see there, it's the UK government avoided providing guidance on some difficult discussions in respect of issues such as reverse triage. This should not have defaulted to HSC trusts and frontline clinical teams to make these decisions. With that in mind from the Belfast Trust were the ones who were responsible for the Nightingale Hospital, that's correct?
That's correct, yeah.
So in terms of any high levels of surge numbers, they were the ones who were going to have to deal with the most number of ICU patients, critical care patients?
Correct, with the support of the other trusts, yes.
Yes, in terms of staffing, and they would be fine,
yes.
Can I please go to INQ 000 377146? So this is an email on the 25th of March 2020, and it's from, I believe, a senior figure within the Belfast Trust, who is talking about boundaries about service expectations for critical care. And it's talking there about starting from a position where nursing workforce is not a capacity. I mean, we've seen a lot of evidence about surge plannings in your statement. I'd just like to go down, please, to the bottom of this email. Thank you. And it's there, it's at number 17. Triage for admission to intensive care will be inevitable. And 18, triage for suitability to continue ICU support will be inevitable. So there seems to be a relationship between an email they sent on the 25th of March 2020 and their statement suggesting that it was beneficial to get guidance. Do you think that there was sufficient guidance provided to healthcare workers in Northern Ireland about the possibility, to be used in the event that issues such as triage for admission to intensive care or suitability continued support, do you think there was sufficient guidance provided to them?
I do, and I'm happy to elaborate on that if you wish.
Please do, and please would you indicate when it was provided and why it was provided in sufficient detail, given that the Trust still believed that there wasn't sufficient guidance?
Well, this was early on and in advance of the work that we undertook. I mean, the first point I would make is that decisions around the appropriateness of clinical care can only be made by clinical teams, and can only ever be made in an estimate of the capacity to benefit of an individual from a particular intervention or treatment, irrespective of what that intervention or treatment is. You know, there can be no blanket policies. You know, there can be no approach which is based on assessment of frailty or age. It has to be based on two simple questions. From any intervention, is there a greater likelihood than not that an individual would benefit? And then the second question is, if the answer is yes, they're likely to be benefit, is that what this individual would wish? The simple issue of consent. There is no doubt that at this time there was significant anxiety within all professions, nursing, medical and others, and indeed within the wider leadership within the health and social care system, including myself, that the demand for access to specialist services, including intensive care, would outstrip our ability to meet that demand. In terms of Chris Hagan's statement, who is a valued colleague who I respect, I do not think, and I do not agree, but I do agree with the expert report by Summers et al., that there can never be a circumstance where we have triage by resource. In other words, whereby the ability of someone's, a decision on someone's, whether they can access treatment is dependent on our ability to provide that. So what I did, recognising those concerns, was I established a COVID-19 clinical ethics forum. First meeting of that was on the 15th of April. In June, we developed clinical guidance, which issued to the service. We extensively worked with the Critical Care Network, and again, this email is from the then chair of the Critical Care Network, with the Palliative Care Network, the Frailty Network, with hospital chaplains, faith leaders. We consulted with the Equality Commissioner, the Commissioner on Human Rights in Northern Ireland. We engaged, we consulted, and we presented that ethical advice and guidance framework. And if I could just finish on this, and then, and what that made explicitly clear was that throughout the pandemic, decisions of this nature needed to be based on professional guidance by the General Medical Council in terms of good decision making at the end of life, treatment and care, and the recommendations by Resuscitation Council and GMC guidance on consent. And that all health professionals continue to be guided by the legal frameworks which they would comply, outlined the Northern Ireland Act, Human Rights Act, Disquality Discrimination Act. And we put in place, as I recall, 2 workshops to work with clinicians who had genuine concerns.
Excuse me for cutting across you, Professor McBride. I think you've set out in your statement a large amount of what was done. The question that I'm asking you is, you have a senior clinician from the Belfast Trust who's saying, in effect in their statement, that they didn't receive sufficient guidance. Do you respect that opinion, that he's saying that actually we didn't get the guidance that we needed, even if you feel that the guidance was there?
I mean, the senior colleague referred to, I respect his opinion. I disagree with his assessment of the guidance and support was provided. I believe that the guidance was provided, and we did, not only did we provide written guidance, but we established workshops to ensure that guidance was understood and was applied.
Because in terms of when you're talking about, that document can come down now, thank you. When you've been redeploying staff, redeploying predominantly theatre staff, recovery staff, is that right? When you are redeploying what is inevitably inexperienced staff into intensive care, don't you need to make sure that there's very strong and very clear prioritisation guidance so that those people, even the senior figures may have that experience, but you do have a number of people working in ICU who don't have that level of experience, and do you need to help them and reflect that level of inexperience with guidance?
Staff who were redeployed, nursing staff, for instance, into critical care with airway skills, were always working under supervision of a critical care nurse. That's the reassurance that I was provided at all times. In terms of, you're correct in what underlying point in your question, which is critical care staff, experienced clinicians make such decisions in conjunction with individual patients and relatives on an ongoing basis. The role of a doctor as a professional is to balance risk and to hold risk, and to at all times act in what is the best interests of the patient. I am satisfied that we provide sufficient guidance. I'm not aware, I mean, there was professional guidance provided by other expert bodies, which we've referenced in the ethical guidance and framework, but I'm satisfied that we provided sufficient clarification on the extant position. Not only did we do that, but we pointed to in that guidance the reassurance that had been offered by the General Medical Council and the BMA in their statements, which is referenced in the document, that decisions made by doctors in the circumstances where the best interests of the patient are concerned, that they need have no concern when they're acting. And I think the other thing I would add is not only...
Can I just check?
No, I think it's really...
Talking about...
I do want to finish this point because it is a really important point. Not only that, but we established in every trust in Northern Ireland clinical ethics committees.
Yes.
And they had the support of the regional clinical ethics committee, which we supported. We made it clear in the guidance that we provided, if doctors faced or other health professionals faced ethical dilemmas, then advice and support was available to them within their individual trusts. So I do think we addressed the concern. But sorry, I
was cutting across
over
you.
you. Sorry.
I just wanted to clarify in my own head whether at this point we were talking about prioritisation guidance or guidance in relation to DNA CPRs. For example, I wasn't quite sure what you were talking about there, because DNA CPRs is the next topic.
Well, I think DNA, we're talking about the totality of care. It doesn't matter whether we're talking, I mean, again, the guidance that we issued talked about cancer care. Mm-hmm. It talked about the treatment and the balance of decisions, and that doctors and others need to weigh up in terms of treating people with COVID versus the delays in treatment to people with other conditions such as cancer. So it talked about decisions to admit to hospital. The guidance was divided into two halves: the ethical principles underpinning, part one, and the legal obligations of all health professions. And then part two was about some worked examples, including decisions around cancer treatment, including DNA CPR as only but one example, and also then pointing to the support that was available to health professionals.
Can I move now to DNA CPRs? Were you aware of concerns expressed during the pandemic of the inappropriate use of DNA CPRs in Northern Ireland?
There was correspondence received by the Minister, raised by elected representatives in Northern Ireland. There were concerns reported in the media. I was not aware of substantive issues in that regard, but there were certainly concerns that had been addressed to the Minister, and the Minister responded to those concerns. Firstly, confirming there was no blanket policy in Northern Ireland, that the same approach in terms of adherence to the guidance and good medical practice from GMC, resuscitation counselling guidance applied, that people would receive the care that was appropriate. So every effort was taken to provide assurances. I'm not certain that necessarily those assurances necessarily provided answers to all of the questions that were being raised, but we did our very best to provide assurance to the public in Northern Ireland.
Two specific points I'd just like to deal with. If we can go to INQ 421784, page 173, it's paragraph 275 of your statement, where you're talking about the department had considered reissuing a DNA CPR form for use during the pandemic to support clinical decision-making. But on the advice of the Regional Clinical Ethics Forum, it's identified that a need for further work. The Department of Health second statement says that the department didn't seek the advice from the Clinical Ethics Forum, and actually the chair of the forum became aware that the department was considering reissuing the form through the clinicians who were concerned about the timing of any reissue. Firstly, is that sequence right, that it was going to be, the form was going to be reissued, and it was only because the chair of the forum became aware that it was going to be issued, rather than it had actually been provided to the Ethics Forum for their views?
With the passage, I can't absolutely be specific in relation to that. I do know that what I can be specific about is that the chair of the Ethics Committee approached myself and advised that this had been raised by a member of the committee who basically felt it was premature to issue a form of such nature. Now, this was about, if I could just explain the context, this was not about a new policy in relation to DNA CPR, but to ensure, as happens in England, I understand, that a decision made in relation to DNA CPR that was made in an acute setting could then be applied, if appropriate, in a community setting. The concerns that were raised to me by the chair, reflecting the discussion at the Ethics Committee, was that it would be inappropriate to do so without raising awareness amongst the public about the absolute nature of DNA CPR, the risk of those being misinterpreted, and the need for there to be significant education and training within the profession, further education training within the profession. And the advice was that should be taken forward as in a holistic way, as is indeed recommended by the UK Resuscitation Council as part of advanced care planning, which I alluded to earlier.
Can I just, in terms of that care and hospital setting, can I just take you back to one of the actions again from the decision log? It's 130312. It's at 618. I'll read it out just in terms of the interest of speed, so I know it takes time to come on the screen. At present, the DNAR does not transfer between acute and community settings. When the patient is discharged from hospital, the GP has to review and should sign a DNR. When a patient is admitted to hospital, then it is reviewed and a DNAR put in place by the hospital doctor. There is a new form which is transferable, but this has never been verified by Department of Health and is therefore not available to practitioners. Can we have clarity on this, please? So is this suggesting that on the 2nd of April there was a form that was looking to be issued that was talking about transferring DNARs from a hospital setting or a community setting and vice versa?
I mean, this was work that was taken forward by Health Silver. It wasn't work that I initiated. When it was brought to my attention, I took on board the advice of the chair of the Ethics Committee and the Ethics Committee, and that form did not issue. From a professional perspective, my position on this is clear. I do not necessarily believe, without the appropriate training and safeguards, that it's appropriate to have a decision that is made in one particular setting, in an acute setting when someone is acutely unwell, basically say that somehow or other that will apply when someone has potentially recovered from their illness and is well and is in a community setting. I do not think that that blanket approach is appropriate. I do think it needs to be reassessed and revisited with the individual and with their family and carers with their permission at each stage in that person's journey.
Do you know?
If you transfer, forgive me interrupting, if you transfer them, you're undermining the principle that it's a clinical decision.
Exactly.
Because the hospital doctor, for example, if it's come from the GP, is not making a clinical decision. He's accepting somebody else's clinical decision.
And my lady, I absolutely agree. And also, people's circumstances change. Yeah. People get better. And their assessment of quality of life and what's important to them changes. And I have reservations about that sort of a form which is applied without appropriate public awareness and without necessarily enhanced training and understanding within the profession. And what we did in Northern Ireland, which I initiated, was, as I mentioned earlier, was initiated work to develop advanced care planning, and we published that policy for now and for the future in October 2022. And it's basically how people can sit down with people that are important to them and discuss what matters to them personally, financially, legally, but also in terms of what they wish in terms of future treatment. And we're rolling out a programme of training for health professionals. Those, unfortunately, and one of the tragic experiences of this pandemic was, and there were lots of extenuating circumstances, those conversations did not happen to the extent that they should have. Although, as I say, there were circumstances whereby the conversations were more difficult because of social distancing and PPE. But what the guidance made very, very clear was that no blanket approaches. Every case to be weighed up individually in terms of what's in the best interest of the individual, and underlined, and it was underlined in the document, about the extra effort that needed to be made to have those conversations with patients, with relatives, and how critically important they were, because otherwise decisions are misunderstood.
Are you accepting from that answer that the guidance wasn't always followed to the extent that it should have been? In other words, hard-pressed medical staff may have been saying that the notice was appropriate when they hadn't had the full consultation with the family, with the patient?
I personally don't know of circumstances where that's the case. My concern is that there were circumstances where that may have been the case, and my concern, furthermore, is that you now have bereaved families who have a level of distrust in terms of decisions were made, why those decisions were made, by whom those decisions were made, and that's deeply concerning. And I think that's why the wider societal approach to advanced care planning, of which the medical element of it is a very significant aspect, is really, really important.
Ever since I've been appointed chair of this inquiry, Professor, I've had complaints from bereaved family members that notices were issued when the patient wasn't able to give their consent, when there'd been no consultation with the family. And also, and I don't know if this is a concern that has come to you, that do not resuscitate notices, I'll call them shorthand, were treated as do not treat notices.
And again, last point first, the guidance that we issued was very, very clear and repeated it in several pages that DNR CPR was only relating to cardiopulmonary resuscitation. It did not apply to other treatment modalities. It is very specific to that. And again, that is only a decision, again, made ideally in consultation with the individual patient, their family. And again, it's in best interest. I mean, it would be unethical to instigate treatment, any treatment, whether it's CPR or anything else, which is likely to be futile, that has no prospect of recovery for a patient, and actually what it's doing is prolonging death. That would be unethical from a professional perspective, but that doesn't obviate the need to have those conversations. But I absolutely accept, if you're in intensive care, you're in full PPE, you're wearing FFP3, etc., the pressures that were on staff, it is possible, although I don't know of cases where those conversations may not have happened to the full extent that they should have.
If I may move on to a different topic, my lady. I'd like to cover long COVID. We talked about data earlier on. At the early stages of the pandemic, was there tracking brought in Northern Ireland for any long-term impacts of COVID, as in came post-COVID syndrome or long COVID?
No.
Do you think there should have been?
Well, firstly, I mean, we weren't, at that time, we weren't aware of the extent or the severity of long COVID. That only became clear really in the summer of 2020. And the first sort of real published study that I recall being aware of was a study from Switzerland in and around July the following year, which pointed to the range of symptoms and the number of people that were affected. However, I mean, I think, as I said in my statement, we do know that many viral illnesses are associated with post-viral syndromes. However, I think the severity and the sort of life-altering impacts of long COVID were not anticipated, and that knowledge only became available to us as we progressed through the pandemic. There were not, absolutely were not, adequate services in terms of a specialist service provided. There were services provided across trusts in Northern Ireland, some of them very, very excellent, but not coordinated services.
Just want to go back to having a tracking effectively. You said that many viruses have post-viral consequences, and that you weren't aware of what became long COVID until effectively the middle of the year. Isn't that the point of monitoring long-term impacts of a virus such as COVID, that you are able to identify at an earlier stage these issues within Northern Ireland?
Well, I mean, I think it wasn't just within Northern Ireland. I mean, I think before you can track something, you have to be able to define it. You have to be able to diagnose it. You need to be able to exclude other conditions. You need to know how to investigate it. And none of those conditions applied early on. So it is, I mean, I agree with you, it would be optimal to say, here is the constellation of symptoms that are associated with post-COVID syndrome or long COVID. These are the systems that they affect in terms of cardiovascular, neurological, etc. But at that early stage, we did not have that knowledge or information to even for us to pose the question to those that would be collecting such data as to what they would be looking for. So in all honesty, I don't know how we would have undertaken that at that point in time, and particularly as we were dealing with so many other issues in responding to the pandemic.
So looking ahead, if there was another pandemic, have you had any thoughts about how you may track any post-viral consequences? Or would the same position apply?
At this present moment in time, the same position would apply, certainly from a Northern Ireland context. I do think that we need to turn our minds to when new diseases emerge. We can't just be relying on the observations of the astute clinician and individuals presenting. We need to have a more proactive means of identifying the sequelae of new infections than we currently have. And as you identify, we shouldn't necessarily, although there will always be a period where we'll be relying on research data to form the basis of how extensive that is. But I agree with the premise of your question, which is that we should seek to develop mechanisms so that we can detect the sequelae earlier.
I believe you said that there weren't adequate services to deal with the response to long COVID. In your opinion, when did Northern Ireland start to have adequate services to deal with it?
Well, I was asked by the Minister to commission work in July 2020, which produced a report which identified that whilst there were some excellent services in Northern Ireland for people with long COVID, that they were not necessarily well connected. There was no, as we later developed, a single-stop shop approach. So you had psychological support, physical support, breathing clinic support, social support, but it was not an integrated service model. So one of the recommendations from that report was an integrated service model would be developed. And the Health and Social Care Board was then tasked in due course with commissioning that service, working with trusts in Northern Ireland, and taking on board NICE guidance at the time in relation to the most appropriate treatment for people living with long COVID. The service was subsequently established, but that bespoke service was established in November 2021. But as I say, the other services that were extant were in place until the specialist service commenced at that time.
Do you know why it took from July 2020, when that work was commissioned, until the 1st of November 2021 for the service to be launched? I mean, that's a year and 4 months.
I think as I say, it wasn't in the absence of other services. Those other services were in place. The self-support services were in place in terms of structured self-management support for people living with long COVID. There were specific services in individual trusts. So those services continued. But certainly the recommendation in the report and what was an aspiration of mine and the Minister agreed was that we needed to have a specialist service for people with long COVID. The Minister agreed to that, I believe, in some initial work was done, a scoping paper was provided to the department, and I think the detail of this is outlined in the Minister's statement in February, and the Minister commissioned the service, I think, in the June of 2021, and there was ongoing engagement over that period. But as I say, colleagues in the Health and Social Care Board, I know we're actively developing the service, but again, they'll be better placed to answer the time that elapsed. But it was complex. It wasn't straightforward to ensure we got the right services in place with the appropriate funding.
Is it a reflection of the difficulty in Northern Ireland of establishing a new service in 2021, that sometimes these things take a long time because you haven't got the capacity to rearrange them? I think the Minister was very clear in his expectations, so there was a degree of urgency with this. Was that ever formalised in a framework document or anything like that? Because I understand that the Minister there are amendments to framework documents which then prioritise different services in different ways? I've no doubt there would have been health policy group colleagues within the department would have issued a letter on behalf of the Minister commissioning the service. There was funding identified of some 1.9 million for the service. I wasn't directly involved in those aspects of the planning, given the other responsibilities I had. As I say, I had carried out the initial work that the Minister had asked of me and pointed to the service model that needed to be developed and subsequently was commissioned and delivered. Moving to shielding, and this is in the latter part of 2020. Northern Ireland paused shielding at the end of July 2020.
31st of July 2020, yes.
And was that following the UK advice that had been coming in the middle of June that this was to be?
No, I mean, I
alternate?
think...
What was the reason for it then?
By the 27th of July, and certainly throughout July, we were having a handful of cases a day in terms of confirmed COVID cases. By that date, thankfully, we had had no deaths from COVID for some 14 days. There was very low levels of community transmission. There also, I had at that stage received the readout from, and then we subsequently published the patient-client council report about the negative consequences of shielding, psychological, social, on individuals that have been affected. That information, along with the low level of community transmission, was fed into a submission to the Minister on the, as I recall, the 16th of June, and included my advice that pausing should be shielded for adults and children in Northern Ireland from the 31st of July. We did have conversations at the UK CMO meeting. That submission, as I recall, also reflected that England were planning to do the same. I don't recall what the other jurisdictions did at that stage.
Okay. And I also think it's right to say that that was a decision that was actually taken by the Northern Ireland Executive to agree to the pausing shielding. I think that was on the 18th of June, around then, and then the decision came in on the 31st of July. Does that sound right to you?
That's absolutely correct. I mean, I think in that paper did go to the executive, because this was a big decision, because we'd effectively, the consequence of our advice had been to effectively remove people who were clinically extremely vulnerable from society for 12 weeks, with all the consequences. And the executive wished to be assured that we have appropriate mechanisms in place. So in that submission, we advised that the community helpline would need to be in place for some time. So that's if people were feeling isolated or lonely or needed assistance with shopping, or because we realised it would be difficult for people to reintroduce themselves into society. I mean, we were still urging caution to people who were shielding at that stage. I issued a statement, a further letter to those who were shielding on the 22nd of June, explaining the rationale for the decision. There was a statement from myself on the department's website on the date of the 31st of July. But we ensured, and we're anxious to ensure, that all of the mental health support, online support, GP support, consultant access support was still available to people who had previously been shielding.
Two very closely related questions. Firstly is, do you think that there was sufficient support provided after the decision had been taken to pause shielding for those who had been shielding? And secondly, do you think that those who had been shielding felt that there was sufficient support provided for them in Northern Ireland after the decision had been taken?
I know that some didn't, and I've alluded to that in my statement. I think in part that was due to the psychological and social impacts of shielding that it had on individuals, and people remained very fearful. Could we have more comprehensively addressed that? Could we have given people greater urgent agency and sense of control? Could we have provided more information and assurance? Possibly. It proved very hard to allow people the ability to make nuanced decisions about levels of risk that were posed to themselves, which is after the shielding was paused, we tried to do. We tried to provide information that would empower individuals to make their own decisions about what was mattered and levels of risk. We did provide lots of support, as I alluded to. I think we could always have provided more. I'm not certain now what more that would have looked like, but I know for many, many people, they felt that there was a lack of support. There was a lack of advice, that it could have been better. And for those that felt that, then I'm sorry we couldn't have done more. And perhaps one of the findings from the inquiry we'll look at in the future is their learning in terms of how we communicate, that it doesn't engender fear, that doesn't disempower, that still gives people a sense of agency in terms of assessing risk and making decisions.
do you think that's a recurring theme throughout the response to the pandemic, whether it be in shielding or PPE or other settings where maybe more could be done to communicate the reasons? I think Professor Gould was talking about winning the hearts and minds of those. Do you think that that's something that could have been done better?
I think yes. I think had we had more time and things not moving at such a pace, we probably would have done things differently. If you even think of the decisions that were made around social distancing in the first lockdown, those decisions were broad brush and made at pace. And if you reflect back, and I think we can all remember back, the language that was used at that time caused huge anxiety and concern. And we were all sitting watching what was evolving around the world. So I think that is a very valid point, that the communication of messaging, how we communicate to older people about, and we saw the impact it had on older people, particularly who were shielding, not seeing family or friends. And they may have made different decisions if they had felt empowered to make decisions about things that really matter and are important. So, and I think that equally applies in healthcare settings with healthcare workers, that it is about empowering people with the information and understanding and winning hearts and minds. And it was quite clear from the email you alluded to earlier on the 18th of March that we hadn't won hearts and minds, and we hadn't secured the trust and hadn't explained often enough or well enough why there was the change in the PPE requirement. So I absolutely accept that is a general learning point, yes.
Again, similar topic in terms of visiting guidance. You weren't directly involved, I think is your wording, in creating the visiting guidance. I presume that you were aware of what the visiting guidance was and what the restrictions were.
Yeah.
So if you thought that the balance was being drawn in the wrong place, you could and would have said so?
Yep.
Again, on that communication point, well, let me ask a slightly earlier question. Do you think that the balance was drawn correctly in terms of end-of-life care?
I know that the former Chief Nursing Officer and colleague answered this question. I don't think we got the balance right in all instances. But these decisions and judgments were finely balanced about, protecting the individuals who were coming in to visit, bringing those individuals into, busy ICU staff and PPE, ICU environments that had been escalated with additional beds. They weren't straightforward, but I think that in the future, I think it is an area that, we can't wait to the next pandemic to start to think about, visiting in those settings, people at the end of life, or visiting in care homes. I think another area where we acted in what we thought were the best interests and the best information that we had.
Can I just slightly head you away from visiting in care homes? If we can just focus on visiting within healthcare settings. It may be the answer's the same, in which case fine, but if we can...
Well, I think the answer is the same, because many people within care homes are actually approaching the end of life, and it is important that we recognise that the sense of isolation and loneliness has detrimental impacts on them from a physical health point of view as well as the impact on family. So I'm not certain we always got the balance right around end of life, decisions around visiting. These are...
Can I just interrupt you there? What would you do differently?
I think we need to perhaps take a more nuanced approach and greater flexibility around particular circumstances, give greater agency to professionals working in those environments. I think blanket approaches more generally are not helpful. At peak times during the pandemic, when transmission was very, very high, there were significant risks to individuals, particularly going into those environments. I think we possibly could have taken a more nuanced approach, and I think we should bear that in mind, that not being able to visit someone, you don't get that time back again. And I'm not certain that, while we're very mindful of that, I think we should have tried to accommodate that more. There'll be many people here today, others represented, who will, I suppose, be living with the sense of guilt and the consequences of not being present.
If I can then move on to another topic in terms of planning and effectively replanning for, I think it was called the third surge, and that was the one in January and February 2021. I think the second surge was slightly later in 2020. Is that right?
Yes, the second surge was actually two surges. It was the wild type and then with alpha.
Tell you what, let's forget the terminology. Doesn't matter. In early 2021, it was anticipated that the critical care numbers were going to be the highest that they had been in Northern Ireland. And it's right that in early 21 that the Minister approved a new regional approach to ensure that any available theatre capacity was allocated for patients most in need of surgery. What was the benefit of bringing in that regional approach of all theatre capacity?
I think I suppose the decision had been made somewhat prior to that, and I think the key decision was made in June of 2020 when we moved away from the emergency response approach to the pandemic into, as we've described previously, business continuity approach. So there was the formation of the Rebuild Management Board. We changed the framework document, which is the document which looks at the relationship between the various parts of the system, and we had a much more centralised approach to rebuilding and restarting health and social care services. That was chaired by the PERMSEC in the department, but it had the chief executives from all of the trusts. So it was very much a Northern Ireland collective approach to try to get services back on track. That resulted then in a number of actions that were agreed in that Rebuild Management Board. There was work undertaken in May, as I recall, 2020, which informed that Rebuild Management Framework. And then the strategy that you refer to in June 21 was basically how we recover, restore and redesign elective services. And again, that was under the aegis of the Rebuild Management Board. But as I say, Avery Trust, the Health and Social Care Board and the PHA were involved in the development of that plan.
Yes, but that's a slightly different plan. That's the elective plan. Isn't this the critical care plan?
Oh, sorry.
In January 2021 about allocating capacity across the entirety of Northern Ireland?
Yeah, I mean, I wasn't directly involved in the development of that plan because, as I say, all of that work was then taken forward by the Integrated COVID Gold Command, which had been set up in the October of 2020.
But as CMO, you must have been aware of the fact.
Oh, yes, I absolutely was aware of it. But at that stage, I mean, just to point out that we were opening up society. My key role at that stage had moved on to the public health response. I was advising on the executive on non-pharmaceutical interventions, the restrictions. I was advising in relation to the rollout of the COVID vaccine, new therapeutics. I was overseeing the work by the PHA in relation to contact tracing. I'd established a directorate on travel. So my focus at that stage was rightfully, in my view, focused on the wider public health response. The PERMSEC was correctly leading on that aspect of the rebuilding of health and social care services and the plan, the critical care plan that you've alluded to. Sorry, I'd misunderstood.
No, I asked a poor question if you misunderstood it. So that was in the summer of 2020 then, when there was that change to...
There was, yeah.
And effectively that you moved on to the broader societal NPI's issues. In terms of, when I say move on, you were no longer the chair of the Gold Command.
That's correct, yeah.
In terms of then any decisions about testing and testing of healthcare workers and the approach to testing of healthcare workers in late 2020, early 2021, did you have any involvement in that?
Early in the pandemic, I had established an expert advisory group on testing, which was led by at associate director level within the Public Health Agency, and that basically had expertise from in Northern Ireland within laboratory services, from within microbiology, virology, and that group provided expert advice to the department, to myself, to my team, and then to Minister about approaches to testing in Northern Ireland.
Because you set out in your statement that on the 14th of January, you issued a letter to all trusts setting out arrangements for the use of a new rapid test for COVID-19 in all emergency departments that delivered results within 12 minutes. And that helped support the management of significant demands on our EDs and on the HSC system as a whole. Was that a letter that was in your name, but you hadn't been directly involved in the process leading up to that, and it had come from the testing group?
I can't recall the specific letter. I suspect it probably did issue in my name, but I can't absolutely now recall. But certainly the advice from the expert advisory group in testing would have been received by the department. I would have considered that and made a recommendation to the Minister. So I was involved in the decision, and I can't now recall, but I suspect I recommended the rollout of that to ED departments in Northern Ireland.
But were you involved in any way in the pilot of asymptomatic testing using lateral flow devices that commenced in January 2021?
Well, yes, in that I was getting regular updates from the expert advisory group on testing, yes. And they were also linking through with colleagues in the other jurisdictions. There were a number of new testing techniques that became available towards the latter part. And again, forgive me if I get the timelines wrong here, probably from the latter part of 2020. In Northern Ireland, we had been piloting from October testing of staff using one of those new testing technologies, loop isothermal amplification. It's basically a very rapid test on saliva to give a positive or negative result. So we had started to roll that out in two trusts, the Belfast Trust and the Western Trust in Northern Ireland. And in parallel, there had been work undertaken by UK Health Security Agency and University of Oxford validating lateral flow devices, as you've alluded to, and considering their utility as an additional measure to ensure effective control of infection within healthcare settings. And that, as you say, was piloted in Northern Ireland, the Southern Trust, in January.
Yes, that's the last point I wanted to come to. So England have been conducting those tests from around the 9th of November 2020. Is that accord, or you're not entirely sure?
I think they'd started piloting it in a number of trusts, and similarly, approach had been taken, I think, around that same time, in December in Scotland and Wales. I know that the expert advisory group on testing had considered how best to expand testing of healthcare workers, looking at the benefits of continuing the expansion of the LAMP test that I referred to earlier versus the benefits of using LFDs. So, I mean, it was there was an ongoing exercise of assessing which tests were most effective, the frequency that testing should be applied, and as you say, that then began, the rollout in Northern Ireland began in January.
Well, if we can please go to 421784, and it's page 237, it's paragraph 408.2. Again, this is your statement, Professor McBride. It's the first half there, thank you. So under the oversight of the EAGT, that's the testing group that you were talking about?
Yes, that's the expert advisory group on testing.
Yes. So the pilot of LFDs had been commenced on January the 2021. A recommendation was made by the testing group on 12th of March to stop the pilot and implement a full rollout of the testing programme. And then on the 4th of June 2021, I wrote to Trust Chief Executive to request that Trust develop robust preparations and plans for significant expansion. Why did it take almost 3 months from the recommendation to implement the full rollout to then you talking to Trust Chief Executives about developing preparations and plans for that rollout?
I mean, again, I would need to look back through the detail of this, but the rollout of the testing of healthcare workers was under the aegis of a subgroup within the Public Health Agency, so I was not within the department directly leading on that rollout.
Would you agree that that took a bit too long in terms of...
Well, again, I would separate out the work that the PHA was doing in terms of rolling out testing versus me writing a letter seeking assurances that there are robust plans and it's actually happening. I think what this was based on, I attended a meeting of the subgroup basically to check in on progress, and I was probably, as I seem to recall, I was simply indicating that, in my view, we needed to do more testing, including, as I recall, at that stage, the testing of non-frontline healthcare workers. So at that stage, we were testing frontline healthcare workers, but I actually felt it was important, recognising the roles and interactions that there are between clinical assistants, ward assistants, porters, etc., etc. I felt it was really, really important that that also extended to people who were fulfilling roles other than doctors, nurses, and allied health professionals. So I say this wasn't me saying, oh, now do this. This was already being done, and I was basically saying, let's get on and make sure that this is expanded further to include non-frontline, although I don't like that word, non-frontline healthcare workers.
Do you think that in Northern Ireland there was sufficient protection for healthcare workers in terms of the support that they were being offered when they were working during the pandemic?
I'm not certain that there was sufficient support available to healthcare workers working anywhere during the pandemic. And I only wish that we could have done more. I mean, looking back on it, these were my friends, my colleagues. My daughter was working in intensive care during the pandemic. I think whether you were working in intensive care, working in a ward, or working in a care home, these were harrowing experiences that people were experiencing. I mean, we were asking nursing staff to facilitate individuals saying goodbye to family using iPads, being present in the most intimate of conversations. So I think that had a very significant impact. I alluded to earlier, what I commissioned in March was a paper on the psychological impact and aftermath of the pandemic. We put in place a number of things after that, including enhanced support for healthcare workers. We established a health and wellbeing framework, which was published on the 16th of April. We established psychological support helplines for individuals, safe spaces within within critical care organisation, where services where people could seek support. We put in place arrangements within care homes for staff, which had information about staff well-being, simple things like tea and coffee. I mean, there was always more we could have done. I know speaking to colleagues, the pandemic had a heavy, heavy toll on those working in very difficult circumstances. And I have no doubt that there was much more that we could have done. We did provide a number of online resources, mental health support, apps which offered access to and signposted to mental health services. But I don't think you can. I don't think you can ever necessarily comprehend the impact that had or adequately address those impacts. And yes, I wish we could have done more.
Finally, Professor McBride, are there any recommendations for how the healthcare system in Northern Ireland would respond? Are there any recommendations that you would invite the Chair to consider? I
mean, I think and I've said this in the closing comments in my statement, that, you know, obviously, when all said and done, this inquiry will judge the response by the Health Service in Northern Ireland in line with this module. I think that, you know, I've said that individuals at all levels within health and social care and within the Health Service performed admirably, did their level best, and did what they thought was right at that time. I think the one message I would ask the inquiry to consider is to consider some of the innovation that we introduced in Northern Ireland, whether that was digital innovation, introduction of technology, new data systems, innovative models in terms of providing care differently, remote consultations, how GPs work differently, how hospital services were provided differently, what we did around bereavement support, what we did around anticipatory care. And I think we just need to free up the health service in Northern Ireland, give it the adequate resource that it needs to actually provide an adequate level of care that the population deserves. Because I think we've certainly demonstrated in the pandemic that if you empower the front line and those working in it, they know the change that need to be made. And I think we have an opportunity to make those changes. The challenges that lie ahead, ironically, for the health service in Northern Ireland, but again across the rest of the UK, will require the courage and determination that saw the foundation of the health service. And I think what we saw during the pandemic is that courage and determination is there, and we just need to liberate it.
If I can just push you just one stage further, Professor McBride, those seem to be recommendations based on things that have gone well. Is there any recommendations arising out of things that didn't go well in Northern Ireland?
I think I mentioned earlier some of the challenges around communication, whether that was communication with healthcare workers or whether that was communication with the public. I think that we put in tremendous efforts to deal with some of the myths and that were being generated at that time. And this was the first pandemic that we faced in an era of social media and 24-hour news. And I think there are some aspects of the communication that we could have done better at a variety of levels. I think there are definitely issues around data, access to data. We touched on this earlier, coding of data, in terms of driving improvements in the health service and assessing the quality of care that people are receiving, but also that data that informs the impact of the inequalities in society. And we touched on earlier in terms of ethnic minorities or people living with disabilities. So I think we have work to do. We have started on a journey, as I've indicated, with the Department of Health's data strategy, establishment of a data institute, but we need resources to ensure that we can realise the benefits of that. So that analytical capacity, the ability to link data sources across government is a key consideration, I think, for the inquiry to consider as well.
Well, Lady, those are the questions.
Can I just ask a couple of other questions in relation to testing, Professor McBride? The reason Mr. Scott hasn't gone into it in any greater detail is, as you know, we have a separate module on test and trace. But can I just ask this for the benefit of those who are watching? In responding to a pandemic, it's well known that one of the things you have to do is test, and trace to try and contain it. Yes?
Absolutely.
Yeah. I've also heard that at the start of the pandemic, around the UK, this isn't just Northern Ireland, we didn't have the capacity to scale up test and trace for a pandemic.
Yes, I restricted my comments on learning to the scope of this module, but as I've said earlier in my response to M1 and M2C, one of the biggest impediments in the early stages of the pandemic, and it forced some very difficult policy decisions, was how to use testing and how to scale it up. You know, and my lady, you had asked me previously in the M2C about the number of tests we had in Northern Ireland, which, you know, at the end of March, for instance, which is somewhere in the region of 800 or 900. We did start testing in Northern Ireland on the 10th of February, and one of 12 or 13 centres across the UK, but then we had 40 tests a day. So we did not have, I mean, that capacity to scale up testing was a major impediment. Similarly, and again, I've said this in my M2C statement, the ability to scale up contact tracing was a significant impediment. And I think that has to be an important learning point in responding to a future pandemic. Now, the tests will be different, and the approach will be different, but that flexible, scalable capability across diagnostics, in terms of how we, for instance, maintain health services, how we separate out, as Chris Hagan said in his statement, more effectively individuals with suspected COVID from people that don't have COVID, so that we can maintain elective services and we don't have individuals who should have been having that treatment delayed. I think there are a range, and we didn't have the tests early on to be able to differentiate that. And as you alluded to, Mr. Scott, earlier, in January I was writing out to trusts, or somebody on my behalf was writing to trusts about how to improve flows in ED departments and actually make sure that we didn't have people with COVID mixing with people who didn't.
You couldn't know if you didn't have a test.
And you can't know if you don't have a test.
Who was responsible in Northern Ireland for taking steps to scale up the testing capacity?
Ultimately,
Just to summarise.
Ultimately, I suppose that would be the department, and the department would task the Health and Social Care Board to work with, which is now within the department, to work with the pathology network, again, which I've covered in my statement.
And when were the first steps taken? Can you remember?
In response to Mr. Scott's statement earlier, that was very early February. There was a four-nation group which was established. I think those calls were occurring, from early, I think maybe in late January, but certainly I can recall from early February, those discussions about scaling up laboratory capacity were ongoing, and we started testing in Northern Ireland in the Regional Virus Laboratory on the 10th of February.
Not just talking about scaling up, do you know when the first steps in Northern Ireland were taken to scale up testing?
There are two aspects to that, and I know we'll cover this in a later module, but we took steps at that time in February and in March to scale up what we refer to as Pillar 1 testing. So that was the laboratories within Northern Ireland, and I established the scientific consortium which had all of the universities in Northern Ireland working with the private sector in Northern Ireland.
So it's February, March.
February, March.
First steps, February.
Yeah, and then obviously we signed up and signed into, I think in early March, the Pillar 2 national testing programme, and the Minister agreed to that. And then we saw that programme rapidly increase.
Thank you. I just thought it's only fair when we're looking at decisions that have been taken that we put it in the context of the fact that there wasn't the scale-up capacity for testing.
No.
Very well, we'll break now. I'm sorry, we're going to one more session to go, Professor McBride. I shall return at 3:20 for the final session. You will be finished this evening, I promise.
All rise.
We now come to the call participants' questions. Professor McBride, they've all got limited time, so I know they'll all be very grateful if you could focus on the question. If we need more information, we can ask for it. Mr. Wilcock.
Professor, I represent Northern Ireland COVID bereaved families for justice, as I think you probably know, and I've been given permission to ask you some questions on two topics, nosocomial infection and DNA CPR, following on to the answers you gave this afternoon. Dealing with the first topic first, nosocomial infection. As you know, Professor, one of the most publicised outbreaks of COVID in a hospital setting in Northern Ireland during the pandemic was in the Craigavon and Daisy Hill hospitals in the autumn of 2020, in which 15 of 32 patients with COVID-19 were reported to have died, and 12 of whose premature death appears to have been directly contributed to by COVID. A serious adverse incident review was carried out by the relevant trust, the Southern Trust, and it estimated that 10 to 20% of patients admitted to hospital in admitted to hospital in the first wave for non-COVID-19 conditions acquired COVID-19 during their hospital stay. And up to 1 in 6 SARS COVID infections among hospitalised patients with COVID in England during the first 6 months of the pandemic could be attributed to nosocomial infection. Do you accept that there was therefore a significant risk, sadly, to the health and life of those attending hospital for non-COVID reasons during the pandemic due to the risk of nosocomial infection?
Absolutely, yes.
Do you agree with the conclusions of the report that I've just quoted into the outbreak at Craigavon Hospital, that a number of deficiencies in the existing estate at those locations, including the physical condition, functional suitability, including a lack of isolation rooms, compliance with standards, including poor ventilation, or lack of single rooms with ensuite facilities, and a lack of effective space utilisation, including poor spacing between beds and multi-bed bays, all contributed to the likelihood of transmission of infection in wards?
I think there's absolutely no doubt that the fabric of hospitals, particularly old hospitals which have limited bed space, have limited isolation rooms and poor ventilation, all contribute to increased risk in those settings.
And that was a feature throughout Northern Irish hospitals, wasn't it?
It was a feature throughout a number of hospitals, but you do have other new builds at hospitals
Yes.
in Northern Ireland, and obviously it was less challenging in those environments. However, this is a highly infectious virus, and despite all the infection prevention control arrangements that were in place, sadly, people did acquire COVID in hospital, and sadly, quite a number of people died as a consequence of that.
What is your view of the proposition that one important lesson from the pandemic and the scale of nosocomial infection that then occurred is that where a treatment could be safely delivered in the community rather than hospital, then that should have been the first response?
I think certainly that is correct, and if we look at those very vulnerable individuals, and a number of those were receiving treatment in a haematology unit and were immunosuppressed, I know that the Cancer Network did look to facilitate treatment, home treatment, alternative treatment that would have kept people out of hospital. However, there are certain conditions which themselves were life-limiting had they not received, those individuals not received very effective treatment such as bone marrow transplant, etc. And unfortunately and sadly, many of those individuals then, as a consequence, were much more vulnerable to COVID.
We understand your answer. Next question. The report also found that, and I quote, instances of inconsistent and inadequate communication with patients, families and healthcare workers during the events they were looking into. In many cases, there were no records of communication of COVID test results to the patients or their families. Similarly, both patients and their families were provided with very little specific information regarding the outbreaks being investigated, which the report found may have led to confusion regarding isolation requirements and visiting restrictions. Are you aware that that complaint was all too common during the pandemic throughout Northern Ireland and not just at the Craigavon and Daisy-Hill hospitals?
I mean, as I alluded to earlier, I think that communication was a challenge. I did read the detail of that report, although I was not directly involved in the generation of that report in preparation for the inquiry today. I think there were significant challenges across all of those areas which apply to a greater or lesser extent in hospitals in Northern Ireland.
In your statement, you state that the Department of Health welcomed the publication of the final report, which we both know contained recommendations for strengthening IPC measures in the hospitals, as well as the systems for overseeing and assuring best practice across the health and social care in Northern Ireland. Have all of the recommendations in the report now been implemented?
Again, the majority of those recommendations were for the Southern Trust. I'm not in a position to advise in terms of those outstanding recommendations. I think that one of the primary concerns in relation to the report was the fabric of old buildings, poor ventilation, and that will require a major investment in estate and major rebuild of some hospital facilities in Northern Ireland and right across the United Kingdom. So unfortunately, I cannot provide you detail in terms of progress on those recommendations. But what I have been advised is that in advance of the publication of the report, the department had been advised that all of the recommendations were being progressed or had been progressed, and the learning was being implemented even before the report was published in 2023, I believe.
I make no criticism, but it took about 3 years for the report to be published, didn't it?
Yes, I mean, I think in context, it's not normal for SAI reports, serious adverse incident reports, to be published, but given the particular impact of this outbreak and understandable concern that was generated, the Minister at the time gave an undertaking that it would be put into the public domain, and the report subsequently was.
Mr McBride, it was my fault. I tempted you into an area that we didn't need to go into, but it's entirely my fault. Can I move on to my second topic?
Okay, sorry.
DNA CPR. You told Mr Scott this afternoon about the various guidances you issued in relation to ethical principles and legal obligations of all health professionals when treating people with COVID during the pandemic. Now, many of the members of the group I represent have made clear that in their collective or individual experiences, their relatives were, and I quote, given up on and simply abandoned to their fate. We have heard, and I know you have read, an expert report from Professor Summers and Dr. Sunderlingam that whatever guidance was given on DNA CPR, I quote, variations in decision-making and conscious or subconscious application of clinical thresholds are likely to have occurred through the sheer complexity of circumstances inherent in the pandemic. In that context, what steps were taken, and you can take it we know about the guidance you've issued, but what steps were taken to prevent such disparities over and above the guidance?
As I mentioned earlier, in terms of the detailed engagement that went on in terms of developing the guidance, there was also, as I recall, 2 workshops with clinicians in Northern Ireland explaining the guidance, working through the guidance from a practical perspective. So it wasn't just we issued a document, we actually, as a system, put in place arrangements to try and ensure what was in the document was understood and was applied. But I did read the expert report, and I do concur with it, and that's why I think my answer earlier about the importance of advanced care planning is crucially important. And again, that was something that was highlighted in the CQC, Care Quality Commission report, looking at this very issue around DNA CPR, which was published, I think, in 2021. And again, it made the point about the importance of advanced care planning, improved public awareness, and improved training within the health professionals.
Well, many people may think that the answer you've just given about the training on the guidance is really part of issuing the guidance. Let me ask the question in a different way. What, if any, investigations were undertaken to establish whether or not there was a disparity in the implementation of the guidance?
There were no investigations undertaken. No such concerns or specific circumstances were brought to my attention for me to investigate or for others to investigate. But I have to say I did watch all of the impact videos from those bereaved in Northern Ireland, and the very specific concerns that were made clear around DNA CPR were not lost on me. And I think we have much further work that we need to do, and hopefully we will do, with the implementation of advanced care planning, and particularly the element of it which is the RESPECT programme, which is recommendations for emergency care and treatment, which is crucially important that we know the wishes of individuals and families towards the end of life.
Just to make sure I understood your answer correctly, are you saying that you were aware of the general controversy over the issue, but you took no steps to find out if there were individual examples of it?
basically any circumstance of that nature would be matters for the individual trusts to consider. If families had raised concerns about their particular loved one and the circumstances around communication or decision making, those would not be matters as Chief Medical Officer which I would have direct responsibility for or would have been in a position to act on. Those would have been matters which, when family made concerns, should have been and could have been considered by the particular trust concerned.
Well, in England, the Care Quality Commission produced reports in November 20 and March 21 on this issue. Do you accept that, particularly given the levels of distrust that you've told us such disparities can engender among people in the community, that a Northern Ireland specific investigation into this issue might have been helpful?
Again, I'm not sure I know an answer to that. I do
But
believe...
you can either say yes or no.
I'm uncertain. I think that what I would say is that individuals, families, have a right to expect that there's explanations provided to them as to why decisions were made, the circumstances in which those decisions are made, and that's made very clear in the guidance document that you referred to, we discussed earlier. And extra effort should be taken in the pandemic to ensure those considerations happened. And if that didn't occur, then I think those individual families have a right for to an explanation as to why it didn't happen. And I would encourage them to engage, if they haven't already, with the service as it was concerned. But the only other thing I would point out is that there were very significant pressures in the system at that time. And as my lady asked earlier, those pressures may have resulted in communication not being as it should have been. And as a consequence, significant mistrust and distrust and hurt and sense of guilt and has developed as a consequence, and we need to address that and redress that.
Professor, thank you very much.
Thank you.
Thank you very much, Mr. Wilcock. Mr. Thomas, I'm very sorry. Did I steal one of your questions or part of one of your questions? If I did, apologies. Don't worry, Mr. Thomas is used to people having their back to him. I'm afraid those who choose to sit over there will put there.
Good afternoon, Professor McBride. I represent FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations. FEMHO has noted the significant and disproportionate impact of the pandemic on Black, Asian and minority ethnic healthcare workers. I want to touch very quickly upon the question that Milady stole from me earlier today. You mentioned that you became aware of the disproportionate infection and death rates among Black, Asian and minority ethnic healthcare workers in April 2020. I heard that correctly, didn't I?
Yes, I think, as I recall, information in relation to that and concerns in that respect were discussed at the UK senior clinicians and also at the UK CMO meeting, yes.
So here's ever so slightly modified question. As a senior figure, once you became aware of these serious disparities, what role did you play in ensuring that effective steps were taken to protect Black, Asian and minority ethnic healthcare workers?
Well, I think, that report was published, that information was available in Northern Ireland, disseminated in Northern Ireland. It was for employers then to carry out risk assessments in relation to individuals in terms of the risk and whether or not they should be perhaps removed from frontline roles. So, for instance, we just touched on the ethical advice and guidance framework that was published in June. That specifically in that document referred to Black and ethnic minority groups who may need to be provided with alternative roles and responsibilities during the pandemic because of the increased risk. So it was something we were alert to. It was something that employers, the trusts providing health services were aware of, and they have a duty of care to ensure that they safeguard the staff within their employment.
Yeah, that I understand, but I suppose what I'm asking you is what systems were in place to ensure that this information was acted upon?
I mean, as I say, there was a specific HR policy cell within Health Gold. I was not directly responsible for that. And I don't wish to appear to be ducking the question and saying, and be unhelpful to the inquiry. But the range of issues that I was dealing with and the complexity of the issues was such that, I had to delegate and rely on other colleagues who had lead responsibilities for this area, and indeed working with colleagues in the Health and Social Care Board and PHA to working with trusts to ensure appropriate action was taken. Because ultimately, responsibility for acting on such information rests with the employer. So to answer your question, I was not receiving or did not receive assurances that appropriate action was being taken, but certainly employers would understand that there's an expectation that they fulfil their duty of care to their employees.
Well, perhaps you can help me with this. Are you able to assist us with any policies or actions implemented to address the disparities identified to minimise what was preventable harm?
At the level at which I was working as Chief Medical Officer, I cannot provide you with the direct operational evidence of that or the practical outworkings of that. That is not something which, as Chief Medical Officer, I would have detailed knowledge of. That is something which others would be able to assist the inquiry with, who were employers at that time with their responsibility for their employees. But again, that is not something which I had oversight or responsibility for.
All right. Let me move on. I've got two more questions than I finished. Perhaps you can help us with this. What do you think could and should have been done to reduce the inequalities for ethnic minority healthcare workers to ensure that they didn't suffer such disparate impacts and going forward in a future pandemic?
Well, I mean, obviously, every pandemic will be different. The issue around increased vulnerability in Black and ethnic minority groups is complex because there are a range of factors that contribute to that. In some instances, it's due to a greater incidence of underlying health conditions. Sometimes it's actually related to some environmental factors as well. I think that there needs to be greater cognizance in the future in terms of the particular risks that individual healthcare workers might experience. And I think the ethical principle of reciprocity is really important in this respect, so that if you have a healthcare worker who's putting themselves in harm's way and is at greater risk, that greater risk should inform decisions about how they work, where they work, and that should be a priority, and the employer has responsibility.
So I'm not following. Forgive me, I'm not quite following it. Are you saying that the responsibility falls on the healthcare worker?
No, absolutely. But what I was saying that was the employer.
Okay.
The principle of reciprocity is a responsibility on the employer to ensure that healthcare workers who are at increased risk, irrespective of what that increased risk is, on the basis of that increased risk, that measures are taken to protect them. And that may include a number of things. It may include, for instance, removing them from higher risk environments where they may be exposed to the virus, or it may be preferentially offering them vaccination, for instance, to ensure that they're better protected in any future pandemic.
Understood.
I think there are clearly issues within Northern Ireland, which touched on earlier, in relation to ethnic monitoring in terms of which needs to be urged.
Okay. Let me come on to my final question. Given your role, would you agree that you have some responsibility to ensure that recommendations are followed through? If not, who should be held accountable for ensuring that lessons are learned?
In general terms or in this specific issue?
Well, if you help us with both.
Okay. In general terms, I think there's a collective responsibility. I think I have professional and personal responsibilities to ensure that learning arising from this inquiry and all its modules is implemented. And I think also responsibility to supporting and informing others who have primary responsibility for those issues in terms of providing advice as to how they might prioritise actions to address those issues. So I think it's twofold. I think it's ensuring that recommendations are implemented and ensuring that those are prioritised and reminding others of their responsibility to implement those recommendations.
Milady, thank you.
Thank you very much, Mr Thomas. Very grateful. Ms Sivakumaran. Oh, you're right over there. Right, far right at the back.
I appear on behalf of the long COVID groups, and I will be asking questions about the provision of care for children and young people with long COVID. Now, I realise it might feel a little bit strange because I'm asking questions from behind, but when you're answering them, please do direct your answers towards the chair.
Okay.
Now, you've explained already that the first long COVID clinics were established in November 2021. Children can't be referred into those clinics, can they?
Well, as I say, there were clinics in place prior to 2021, as I explained earlier, but the first commissioned service for people suffering, adults with long COVID, was in November 2021. In Northern Ireland, we have sought to fully implement the relevant NICE guideline, NG 188, and in terms of the advice to the Health and Social Care Board to commission the service, that was to provide a service for adult patients. I can expand on that if you wish.
Well, just focusing on children and young people for now, I don't think you've actually quite answered that. Children can't be referred into those clinics.
Well, the NICE guidance, the relevant NICE guidance that I referenced, said that there was a lack of evidence in relation to the most effective approaches in terms of treatment for children. In Northern Ireland, that NICE guidance was discussed with the paediatricians in Northern Ireland, and there was an agreement that individual children with long COVID would be referred into existing paediatric services, this is the situation at present within Northern Ireland.
Okay, and so taking from that, in being referred into existing paediatric services, they're not referred into any dedicated long COVID services?
But being referred into paediatric services, the paediatricians then would determine the most appropriate approach to deal with the various sequelae that children with long COVID would be experiencing. And so they would have access to the full range of paediatric services and other specialists that were within paediatric units in Northern Ireland.
Indeed, and the inquiry's heard evidence from long COVID experts, Professor Breitling and Dr. Evans, and they've said at paragraph 84 of their report to this inquiry in Module 3 that regions with fewer patients of long COVID and lower rates of COVID-19, this is in relation to children and young people, are likely to have inexperienced healthcare professionals. And that supports the need for a virtual multidisciplinary team which could deliver post-COVID children and young people hubs, deliver services through these hubs. Now, you've explained how it's going through general services, but would you agree that a virtual multidisciplinary team which delivers through a long COVID children and young persons hub could provide a specialised age-appropriate support for children with long COVID?
Yes, I did read that report, and I think that's a very good suggestion. I think a similar approach has been taken, for instance, in primary care by the Royal College of General Practice, whereby general practitioners with a particular interest in long COVID have formed a virtual network to provide mutual support and to provide regular updates. I think there is much merit in that model, yes.
And would you recommend that such a service is provided for children and young people in Northern Ireland? Well, obviously that's ultimately a matter for the inquiry to determine the merits of that. I think personally there is much merit in it. It would be ultimately a decision for a minister. I certainly would wish to engage with local paediatricians in Northern Ireland who obviously are more expert in this area than I, and those with a particular interest in this area as to the relative merits of that. Thank you. My lady, Mr. Scott's covered the second set of questions that we have permission for, and we no longer seek to pursue that line of questioning with this witness.
Thank you very much for your help. Mr. Jacobs, I'm afraid Mr. Jacobs is also over there. I think they're testing you, Professor.
Yes, I find it very difficult not to look at people when I'm speaking.
It's difficult. I know. Well, look at them while they ask a question, and then turn around when you answer it.
Okay.
That makes you feel better.
What was that? Sorry. Look.
look at Mr Jacobs while he's asking the question,
Okay,
and turn around
okay.
to me. to answer.
I don't think that was a command. I don't think you have to, but if it makes you feel more comfortable. Professor, a small number of questions on behalf of the Trades Union Congress. First topic is the discussion earlier in your evidence that regulatory inspections were right to be reduced on the basis, in part, that it would add pressure. You referred to continued inspections adding further pressures to already pressured services, with staff being pulled in multiple directions. Clearly, Professor, hospitals in month one of a pandemic or in its early stages are going to be under all sorts of pressures, reorganising staff, reorganising equipment and so on. Might it not actually be important in that context to have that regulatory pressure on health and safety, difficult though it may be, so it doesn't get lost amongst those competing priorities?
I mean, I think you make a valid point, and it is an important consideration, as I alluded to in my response to Mr Scott earlier, that these were finely balanced judgment calls. I think that it's important to point out that the primary responsibility for the quality and safety of care resides with the provider of that care in Northern Ireland as across the rest of the UK, and then the second order responsibility with the Commissioner, in this case the Health and Social Care Board, working jointly with the PHA. Regulation is an inspection, is a belt and braces that is the external eyes and ears to provide assurances that all is well, or to point to things that are not well. And there is no doubt that in taking the decision to pause the inspections of the hospital, essentially cease the hospital's inspections in Northern Ireland, you're losing that external scrutiny. But again, that was a decision we made, balancing up the adverse consequences in terms of pressure on staff, potentially introducing infection, and these were finely balanced decisions. But I accept the point you're making.
Professor, if we put that finely balanced decision to one side and focus on the future, on the next pandemic, if we are going to express dismay in this room as a society at the loss of life of healthcare staff, including the disproportionate loss of life of black and ethnic minority health workers, if we're going to endeavour to keep them safe, in the next pandemic, do you think actually that finely balanced decision should be made differently, and it should be recognised that actually in the early moments of crisis, when safety is most precarious, when vulnerable groups are most at risk, actually that's when regulatory input needs to maintain, if not increase?
I do think that in planning and preparing for the next pandemic, we need to consider innovative ways in terms of how we might maintain a proportionate inspection approach, using perhaps, as we did in Northern Ireland, certainly within the care home sector, remote inspections, or a hybrid approach to inspections using technology, and in such a way that it remains intelligence-led, evidence-based, and proportionate to the other pressures. I know that in Northern Ireland, the RQIA are currently looking at such innovative approaches to how inspections might be adapted to ensure that a degree of oversight could be maintained should similar circumstances arise again.
And clearly the objective is something that's meaningful rather than a burden on services, but it sounds perhaps as if we're pushing at an open door, at least in the general principle of meaningful regulatory input, including in the early stages.
Yes, I mean, I think we did utilise the skills of RQIA in the pandemic responses. Say they're all qualified health professionals. They established a service support team, and I know for later modules, which was essential in providing support into care homes. But I do agree that from my perspective, and certainly from a Northern Ireland perspective, I do think that we need to, again, re-examine the relative merits of that enhanced scrutiny in terms of eyes and ears from outside, that fresh look as to how that might be maintained to some extent in a meaningful and proportionate way, such as you've suggested.
Professor, I'm going to try and deal briefly with a slightly different, perhaps related point. Paragraph 68 of your statement, I don't think you need to turn to it. You describe analysis to the effect that occupations with higher risk, included those with higher levels of close contact, including health and social care, and it also included those with low pay. Would it be correct to say that those in frontline healthcare roles on low pay, porters, cleaners, and so on, are at the intersection of two risk factors, lower pay with higher associated comorbidities, but also a setting and type of work that carries risk?
I would absolutely agree with that, yes.
And how does pandemic response in the next pandemic account for that, account for those low workers in healthcare low paid workers in healthcare settings being at that particular risk?
Well, and you would expect me to say this as Chief Medical Officer, the primary objective must be to improve the health and well-being of the entire population and reduce and address the huge inequalities that we see in health. The fact that people live longer because of their environmental, social circumstances, the socioeconomic circumstances is invidious. And I know it's not a matter that this inquiry can address, but certainly from my policy responsibilities, working with other government departments, our primary objective under Making Life Better, which is the executive's policy about improving health and well-being and addressing health inequalities, we must invest more in addressing the underlying factors that contribute to that, the societal factors, the employment factors, that actually put those individuals at risk. I think specifically, though, looking at very practical basis in terms of what to do within employers. When I was chief executive for a short time within the Belfast Trust, I established a programme of staff wellbeing programmes, health and fitness programmes. I think in health, we need to be an employer of choice. We need to demonstrate that when you work for the health service, apart from those that we provide care to, working for the health service, that we will invest in you, in your health and well-being, and keeping you fit and well. As employers, I think we have a duty of care to invest in the well-being of our staff, because that, we know, translates into better and higher quality patient care.
And I think I've probably gone over time, for which I apologise. Thank you, Professor.
Thank you very much, Mr. Jacobs. Ms. Samantha Jones, I'm not going to make the same mistake this time.
Thank you, my lady. I'm very grateful. Professor McBride, I ask questions on behalf of the Disability Charities Consortium. I've got permission to ask you questions on 3 topics. So turning firstly to the topic of capturing inequalities, you say in your statement, and we don't need to turn it up, at paragraph 424, that in terms of data and analysis with respect to inequalities in Northern Ireland, we were able to review the impact of the pandemic in relation to age, gender and social deprivation. And I know you were asked some questions about that earlier. Can I take it from that you were not able to review the impact of the pandemic on disabled people?
That's correct, and I think, and again, I've read the witness statements from some of those that you represent, and I would agree that the recording of data on those who are disabled is very poor within health and social care systems. We don't have, at this moment, a standard definition of what we mean. We have a definition, a legal definition of what it means in terms of, physical, mental, and enduring. We would need to do a specific piece of work looking at, I don't want to use technical terms, but ICD-10 codes. So we'd need to identify the conditions that would result in people being disabled, and then we would need to maintain a way of capturing that information, recording that information. That does not exist at present, and I don't think that quality information exists anywhere in the UK at the moment, and that needs to be addressed.
And is that work being done currently by the department in Northern Ireland?
No, it is not being done currently by the department. Again, it would require a cross-departmental approach. It would require input in Northern Ireland context, certainly from health, but also from the Department for Communities and others. It would require a cross-government approach, because obviously different parts of government hold information and they all hold it in different ways, and that there isn't necessarily a consistent sharing of that information. And we would need, so for instance, we could use those individuals who are on disability living allowance as a mechanism to ensure that we extract that information from health records.
One follow-up question to that. We've heard from earlier witnesses about the Office of National Statistics was able to collect data on the impact of the pandemic on disabled people, amongst other protected characteristic groups. Is that data something that the department could use to look at the disparities in the impact on disabled people? And if not, why not?
It certainly, I mean, again, I think the data even in the UK, sorry, in England, is not robust. And not well recorded. I'm not in a position, because it's, again, not under my direct responsibility to answer whether or not it's worse, more poorly recorded in Northern Ireland than elsewhere. In ONS, I mean, Northern Ireland, the Northern Ireland Statistical and Research Agency, which is an arm's length body of the Department of Finance, conducts statistical analysis to inform policy, and that could be an area working with other departments, that information could be developed in a similar way as you've described with ONS.
Thank you. Moving on to the second topic then of shielding and those in the clinically extremely vulnerable category, which I'll just refer to as the CEV for shorthand. Again, we don't need to turn to it, but at paragraph 129 of your statement, you say that as indicated above in other paragraphs of your statement, that the CEV list was kept under continuous review, and on the 26th of November 2020, the department announced that adults with Down syndrome had been added to the clinically extremely vulnerable list, as recent evidence indicated that adults with Down syndrome were in the high-risk category for severe disease. Now, first question, is that a decision that you made with your fellow CMOs to add adults with Down syndrome to the CEV list?
Yes, representatives, we work very closely across the UK. We had a UK expert panel, which members of the department were involved in those discussions, and the recommendations from the expert panel came to 4 UK CMOs for consideration, and we did approve it at that time.
Do you recall that the decision, the date of the decision, when you made that with the other CMOs?
I don't now recall.
If I say this, we've seen in other documents, and I can take you to some if we need to, that a collective decision was made on the 30th of September 2020, and that was based on the interim Q-COVID findings. Is that something that you would agree with?
In terms of the time frame, I accept, your premise or your point that it was the 30th of September. It was certainly based on Q-COVID analysis, with the passage of time now, I don't recall. Sorry, I'm anticipating your next question. Sorry.
Thank you. So my next question is, without needing to take you to those documents, is that we have the decision was made collectively by you and your CMO colleagues on the 30th of September 2020, but we know from your statement and other documents that it was only on the 26th of November that the department announced that adults with Down syndrome would be added to the list. Can you account for why there was that delay in that announcement from the decision?
I don't now recall. I mean, my recollection, and obviously it's not accurate, was that when that advice was provided, the decision was made to add it decision was made to add it to the list, and it was added. I can't explain what the rationale was or what the factors were that contribute to the delay in actually adding it officially to the list.
You say at paragraph 129 of your statement that once that announcement had been made, you wrote to adults with Down syndrome to advise them that they had been included on the list, and you advised what this meant for them. And in your statement, you've exhibited a template letter detailing that advice. Now, just in terms of when that letter was sent, it's dated in the on the template just November 2020, but we don't have a specific day on when it was sent. Can you recall when it was sent in November, and would it have been after the announcement was made by the department?
I think my recollection is that we all made the announcement at the same time, and we all issued the correspondence at the same time, given the close cooperation that was going across the UK. I don't recall the exact date. I do recall that we also issued an easy read version with the letter, so that again it would be understood by people with living with Down syndrome. but I don't recall the dates or timing.
Yes, but to be clear, it's likely that you would have sent that letter after the announcement was made by the department. You wouldn't have sent it earlier than the 26th of November.
I think that I think that's a reasonable conclusion. Yes.
And I appreciate your earlier answers on this, so you might not be able to help me, but are you aware of any negative impact that was or could have been caused to adults with Down syndrome by only informing them that they were added to the CEV list on the 26th of November or thereafter, when the decision had actually been made at the end of September?
I'm not certainly. There was a reasonable expectation, and I don't know the circumstance, and I can't recall that when, as UK CMOs, we made that decision that advice would have been acted upon. I don't know why the apparent delay or what the rationale for that was. I'm sorry.
Okay, thank you. My third and final topic then is on DNA CPRs. And paragraph 275 of your statement, and again, I don't believe we need to go to it unless you'd like me to take you there, is that you say prior to October 2022, you had interim guidance in place, and that was in the form of the COVID-19 Guidance, Ethical Advice and Support Framework, which supported DNA CPR decision-making for clinical teams. Now, could we just go to that guidance, if that's possible? It's INQ 30381-325. So that's it there. I appreciate there was an earlier version that was published in June 2020, and this is the version that was updated on the 21st of September 2020. And if we could just go to page 29, please. You can see at the bottom of that page, that's the section that is numbered 7.5, and it's the section on DNA CPRs. Thank you. And then if we can go over to page 30. And it's the fourth paragraph down, which I'd like to ask you about. So there, as you can see, it says, and I'm sure you're familiar with this anyways, DNA CPR decisions should be made in conjunction with other members of the multidisciplinary team, including the GP. Now, my question is, the guidance doesn't say expressly that the decision should be made with the individual or their family. Is that something that you would agree was not expressly stated in the interim guidance at the time?
Again, this is a 63-page document, and I think if you go to page 5 and page 14 of the document, it is explicit in stating that there needs to be discussion with the patient and also with family. I think it's page 14 talks about a clear explanation, and that clear explanation is of critical importance. And I think the term is to avoid future misunderstanding. So in the executive summary, it makes it very clear. So that's on page 5. And then that same point is reiterated at page 14. And then there's a section, which again isn't here and isn't displayed, around decision-making during the pandemic and when there are resourcing pressures. And again, it's made explicit there. So I've just urged caution in terms of taking that in the wider context of the guidance itself.
But it would be better if the guidance is saying include members of the family and the patient where possible, if when you have a list of objectives or criteria to be deployed, then it says there family, even if it says it elsewhere in the document, wouldn't it? Well,
it says it on the first page of the document. If you go to page 5, it is explicit, and it is explicit throughout the document, my lady. But I do accept the point that referencing earlier pages would have been helpful, but it is
because
explicit.
People go to chunks of it, don't they? We all know.
Yes.
We have this document sent through from some body above, and we'll go to the page we find most useful. If some clinicians took that page, they're not going to see the reference to
The only other point I would make, my lady, is that GMC guidance on this is absolutely clear. I mean, that was published, and the GMC guidance was published in 2010, so this isn't the only document. And the legislation, the rights-based approach, and all the relevant legislation was referenced in this document, and specific emphasis in both the Resuscitation Council UK guidance of 2016, GMC guidance is about discussions and issues of consent with individuals and their families. So I think taking this page in context, I think I would just caveat it with wider guidance and earlier parts of the document.
Ms Jones.
Thank you, my lady. That's going to be my final question, so thank you very much.
Ms Polishchuk, where are you? Oh, that way. Right. Can you see?
I think hopefully I'm in the right
Yes,
direction for
I
you
can.
to look at me. And if I'm lucky, if you're lucky, I think I'm the last questioner, so double bonus for you today. I ask questions on behalf of clinically vulnerable families, who are a group who advocate and provide support for the clinically vulnerable, the clinically extremely vulnerable, and of course their families. And I just have one topic of questions today about the design of the shielding program, and in particular the way the protection of shielding was directed towards individuals, not their families or the wider household. So first, did you or your office give any advice when developing the shielding program about how many clinically extremely vulnerable people lived with others, and particularly with other people who weren't shielding?
We didn't have those numbers, but what we did do, and I think it is in the letter which issued in and around the 27th of March, we did provide guidance to people who were shielding about the what others living with them and carers, the steps that they should be taking to protect them. So the letter wasn't just directed to those shielding, but also contained advice, to the best of my recollection, contained specific advice to individuals living with individuals who were shielding or providing care to individuals who were shielding. And we reinforced that on multiple occasions during media briefings and further statements from the department.
So that's right, Professor, but it's also correct that in that same letter, we know that shielding individuals were told to socially distance from those that they lived with, so to maintain a 2-metre distance from them and to eat separately from them as well, for example, in conjunction with their loved ones taking those steps. Yes,
obviously the practical implications of that, if you're living in a small home, with other individuals living with you, the advice did say about, if you can, use separate bathrooms, et cetera, going into the kitchen when others aren't there, ventilation. The practical outworkings of that, I think, for individuals who were shielding and indeed for those who lived with them was extremely challenging, and I accept that.
Thank you, Professor, because you've anticipated my next question, which was whether you gave any advice on the feasibility and the real-world challenges for those people who were trying to follow that advice.
We sought to do so. Whether we effectively and comprehensively did so is another question, and obviously those who were shielding did communicate directly with me at the time, and I think it was undoubtedly more difficult for some who were shielding than for others. We were also, when we issued that guidance, we were very keen to emphasise the important other things that people should do in terms of their physical health, their mental health, and sources of support that were available to them. But I accept it was the advice for many would have been difficult to implement.
Thank you, Professor. You've said that there wasn't that data available to you about numbers of those shielding who were living with others at the outset. We know that in England, at least, ONS data by July 2020 indicated that 74% of CEV people lived with others and 15% lived with children under 16. So once shielding was implemented, was equivalent data available in Northern Ireland? And if so, were those numbers ever used to revise or advise on that individual focus of the shielding program?
My role, as I've indicated in my statement, was to provide the professional technical advice in relation to shielding and who was clinically extremely vulnerable. The operational aspects of the implementation were with policy colleagues within the department, including the issuing of letters, etc. There was some analysis conducted. I don't have the figures with me in terms of the number of people who were shielding in Northern Ireland. I think we probably had more people shielding in Northern Ireland per head of the population than elsewhere. But I don't have the breakdown that you've just described in terms of those living with family, other family members, or those living with children.
Thank you, Professor. Milady, those are all my questions.
Thank you very much indeed. I think that completes the questions now. another very long day for you. Oh, Mr Wilcock.
It may complete that. We've just within minutes sent a request for an additional Rule 10. It may not have reached you yet. It'll take about a minute to answer and a minute to ask.
As it's you, Mr Wilcock.
It's very kind. Thank you very much. Professor, I asked you questions about whether the recommendations of the Craigavon Serious Adverse Incident Review had been implemented, and you responded by correctly observing that the majority of those were directed towards the Southern Trust. It's right, however, isn't it, that one of the recommendations was directed both to the Trust and the Department of Health, PHA and the Health and Social Care Board, and stated that Northern Ireland should implement a Northern Ireland Infection Prevention and Control framework to provide consistency between trusts, and that the absence of such a framework had resulted in a variation of investment in the regional IPC workforce, workforce resources, policy and management between trusts in Northern Ireland. The question I've been asked to ask is, has that been complied with?
If I understand the question, or part of the question correctly, it's about an IPC framework. In Northern Ireland, we do have an IPC
Was
framework.
one introduced following the...
No, we've always had a regional Northern Ireland IPC framework.
Right.
I'm not directly responsible for that work. It was taken forward by the Public Health Agency. That is in existence. I noticed one of the expert reports indicated that it wasn't aware whether there was or whether there wasn't. There was, and has been for a considerable number of years, a regional IPC report. As to the consistent application of that, again, I'm not in a position to advise. I think it's back to the other expert witness reports which talked about hearts and minds. Healthcare workers need to be empowered to implement the controls, need to understand the benefits of that. There needs to be significant investment, Chair, I would suggest, in terms of infection prevention control teams and infection prevention control training. Traditionally, it's the preserve and expertise of infection control nurses, but it's everyone's responsibility. And I think that one other learning from the pandemic is that we need to do much, much more in this space, including ensuring that we have an awareness of and training around infection prevention control in those healthcare workers working in care homes, in pharmacy, etc. Because learning from the pandemic was we needed to invest considerable time and effort, appropriately so, in skilling up those individuals. So it is additional investment, additional training, and ensuring more consistency of approach.
Professor, you want to get me into trouble.
Sorry.
Does it come to this? There was a framework. Whatever the framework was, it hasn't been altered, enhanced or amended as a result of the inquiry's report, but you accept that more investment in this area is needed in Northern Ireland. Is that a summary of your answer?
I don't genuinely know whether the framework has been updated since the pandemic. It's not within my direct area of responsibility. I do absolutely accept there is more investment required in this area of work.
Thank you very much indeed. Thank you, my lady.
Thank you, Mr Wilcock. That now completes the questions for you, Professor McBride. It's been another long day for you, and I know the demands that the inquiry has been making on you. I wish I could say it's the last time we're going to call on you. I honestly don't know.
I was hoping you would say it would be, my lady.
know.
We're fed up seeing me.
For the likes of you who keep coming to help me, I meant to check at lunchtime, but the trouble is I've got so many different modules that I can check
appreciate
with all
that.
the
I do
teams.
appreciate that.
Anyway, we're really grateful to you for the help that you've given, and I'm sorry it's been such a long, and I hope not too gruelling day, but I suspect it has been quite gruelling. But anyway, thank you.
Well, I stand ready to assist the inquiry in any way I can, my lady. Thank you.
Thank you very much indeed. 10 o'clock tomorrow, please.
All rise.